this is full circle for me. It was more than a decade ago. See, it was 2010 that I met Doreen Todor. It's a small world here, so. But Doreen is still at VCU, and I would sit in the basement and work up these balloon brachytherapy plans and dosimetric comparisons. And I was on older platforms subtracting the skin and trying to Boolean out this, how deep does it matter for the dose for cosmetic outcomes. But he would humor me and let me bring him my Excel sheets that were wrong at first and at second and third. But he tutored me through that. And then after that, my experience with physicists was really different. Doreen really supported me. And then I went on the interview trail. And I was at USC, and I can't name names, right? But I showed up, and so my project was on balloon brachytherapy for the breast. And I get in with this panel of physicists, and they start asking me questions. And the head physicist there is like, well, this and that was something called TG43. I'm a med student. I don't know any physics other than like basic Newtonian. And I'm like, I don't know. And he looks at me like I just don't belong. And I just hot flash, and I start to sweat. And this other physicist looks at me and he's like, hey, he's just a med student. And the guy's like, I don't care. This was his project. He should know this. And I walk out just burnt to a crisp. I was talking with Vic, and I spent some time at the University of Utah as a medical student too. Thought I had a great rotation, just made some friends, learned a lot. And then they did like an exit interview so I wouldn't have to come back for a residency interview. It was kind of them. And I was sitting in front of Bill Salter, and he asked me how the exact track worked. And I was like, I don't know what that is. Again, I hot flash. I needed a towel. But I hope that this is relevant. I tried to think, what is it that a physicist would want to know? I'll give you what you want to know up front. We admit as clinicians, we don't really know all of what we're doing and what we ask you to do. And when we want just a little more dose there or a little more off the OAR, we know it's not possible. So I've shown my cards. Now the rest will be fun. How many, by raise of hands, radiation oncology specific physicists? Okay. And imaging? Okay. Quantum? Neither. Next button. Oh, let's use that mouse here. That'll actually be nice. I can walk. So disclaimers, no financial disclosures, no affiliation disclosures. This is for 60 minutes. That's more of a warning than a disclosure. Based on prior data, local control decreases after slide 47. So I do want to cover some basics of cervical cancer. I didn't know how many would be more on the imaging side. And how many of you do brachytherapy? So quite a few. And gyne brachytherapy specifically. Neat. While I was at the University of Nebraska, I got to learn a little more about brachytherapy. I started mostly in the gyne. And then we started some of the skin brachytherapy. Who you do some skin brachytherapy? It's voodoo. It's kind of funny. I will put a plug in. I thought skin brachytherapy was okay. I started that program at the University of Nebraska. But there is a superficial treatment. You're getting a presentation that I will now completely relinquish any of my skin brachytherapy for. And that's the truth. comprehensive cervical cancer plan. So what I wanted to do, you see the brachytherapy side really closely. I wanted to kind of bring the before and the after and the why. What are these guys thinking? So some of the external beam and how do we interdigitate all this? I want you to see part of what I always want for my physicists. I wish you could be there at consultation and see the patient. And I wish you could be there as we watch, tumors regress on external beam. I know you're there. And I want you to be there. I wish you could be there the 3 months afterwards when there's a complete response. So I want to kind of bring you through, I guess, what I see bird's eye view, the importance of brachytherapy, the evidence for and the clinical implementation. So these constraints that we have, we'll dive a little bit into those of we're not just, feeling the wind and saying this is what I want my dose constraints to be. We'll do some case-based because that's most interesting. And we're going to look at each other a little bit. Would it be helpful if we got lights down a little bit? Let's do that for maybe some of especially the images. Some of my charts might need the lights down. Dad jokes will definitely be in there. It's a complicated lighting system, actually. When we do tumor board in here, I don't touch it.
Smashing.
It's smashing. Need the improbability, right? That was, maybe let's get this one down.
I'm just hitting random buttons.
That's good. This is good. This is good. We'll see penguins in a moment.
We'll work on it.
Okay, we'll work on it during the light show. Other people's wisdom mixed in that have nothing to do. Anyone a Monty Python fan? And now for something completely different. That's my style. And then we'll get to the answer to the ultimate question of life, the universe and everything. A little bit about me. This is Henry. He's 13. Joseph, he's 11. And Maury is 9. I know what you're thinking. He had 3 kids and none of them have teeth. So we had a 4th. That's not what we wanted, some teeth. I was actually hoping for a girl, but I don't play favorites. I don't have favorites, but clearly one of them is winning. I gave this talk to my kids, and this is about what I expect afterwards. So also, Ray Station, you said that you're doing things with small animal research. I got 4.
All right.
On a more serious note, this is our paradigm. Nothing that we do at work, no papers that we write, no salary that we negotiate, nothing in our work will make up if we have failure for seeing patients one by one. I think that cervical brachytherapy is really one of the places that shines, where nobody comes in looking the same. I do find that the times that I'm not rushed and the times that I look at a scan and I see a patient, and that's why I want you to see faces, that's when it changes what I do. So come with me a little bit. This is the obligatory statistics slide, right? Most recent cervical cancer data. On the top, we have incidence. On the bottom, we have mortality rate. And so we see that we had a big sort of start to slope from 1993 up to about 2001. I started doing some research on AI and trying to figure out what that correlated with. And what I thought it correlated most was the start of Walker, Texas Ranger, when it started and ended. Just a tribute to Chuck Norris, that his tears cure cancer. It's a shame he's never cried. Real statistics. So the United States, you see, we're dark blue. We see a disproportionate amount of cervical cancer, you and I, because they all come to us. So many, unless they're found in the very earliest stages, then it's surgery only. And everybody else will get surgery and we'll find out they need radiation. Or most of the cases in good high volume centers, we'll see them, we'll work them up as tumor board, and we'll know that they need radiation chemotherapy up front. Don't panic. The good news, really aggressive international outreach. WHO is looking for vaccinating 90% of those red areas, okay? The Gardasil vaccine is now approved up to the age of 45. I do want to touch, people really misunderstand the HPV virus correlation with cervical cancer. When I was Doreen Todor's student, I remember walking in and asking a lady detailed information about her sexual history because we really thought that it was driven, that was a sexually transmitted disease. And now we've come to understand incidence up to 90% of people will have encounter with HPV. If you check toddlers, there's one study where 30% of them had HPV. And so it's that everybody gets in contact, really, that there are risk factors, one more than another, but in the end, it's almost, it's not quite to the level of flu, but we will see it. But it's those that don't clear that virus. The virus does a really interesting thing where it's inserting its replicative DNA into our DNA, but it does it at a certain position. I don't remember, I forget if it's E6 or E7, but it inserts it and it disrupts the retinoblastoma gene, which is tumor suppressor. And so then it's just a predilection towards developing cancer. And so physicists, as we're talking, these are cervical cancer, head and neck cancer, anal cancer, the squamous cells that we see that in. And so that vaccine is going to play a big part. Screening is a difficult one because that relies a lot on the patient factor. And as you know, we can do a lot when people come to us, but it's getting them to us. It's letting them know that they should come. It's stigma, all sorts. And so it's a 90-70-90 is what they call the plan. And that other 90% is appropriate treatment to 90% of patients. This was one of the big pushes by the American Cancer Society. 26 million girls was the goal. This did start in 2025. So that's kind of a beautiful, optimistic, you remember that curve with the Chuck Norris jokes on it, that really might plummet. And then our map with the heat really in Africa, Bangladesh, some Pakistan, that will save more lives than I will ever contact with brachytherapy is a really neat part. So the shining star, no substitute for brachytherapy. Pattern of decline in use we'll talk about, and then quality and timing, why that's such an issue. So one of those charts we needed the lights down for. Sorry that the black turned out okay, I guess. But this is a long list of charts that just demonstrate overall survival difference. When people chose to cheat, when people said we don't have brachytherapy, and so they didn't refer those patients to a high volume brachytherapy center, you see in white, if they did an external beam boost, that could have been IMRT or SBRT. The 4-year cancer-specific survival dropped from 51 to 46%. Some studies even a little larger. And these are SEER database. So these are population-based studies, lots of people, but not very good detailed data. The hazard ratio up 1.8, that's 86% more. The brachytherapy benefit we see in the Coronaga is that even if it was delayed, so we talk about package time. Everyone familiar with package time? Package time in brachytherapy, cervical cancer, before there was chemo introduced, it was just external beam radiation. And we saw that some people, we said, well, head and neck and cervical cancer actually have a lot of correlates and parallels. And in that, the time that you start treatment to the time you finish matters. Okay, and that figures into some of our calculations, a little more into reach back into your radiation biology of time, dose, fractionation, but that time factor is really an important part for squamous cell carcinoma. After we reach 56 days, okay, then after that we see every day delay could be up to 1% loss in local control. But we see here that if you're using brachytherapy, it still beats external beam, even if we're delayed. The decline in use, these are several studies that just demonstrate, again, brachytherapy did really well in the 90s because brachytherapy was one of our original gangsters, right? That's like cesium, I mean, you got your needles and all sorts of kinds, your Hayman's capsules, and that was the way that we got radiation to the source that we couldn't when we had earlier linear accelerators or cobalt machines. But here we see the decrease in utilization from 83 to 58%, almost half, Kumar et al., of US patients treated without brachytherapy. But then we see Coulson et al., utilization has started to reverse. So when we take the 2018 and on, our message of brachytherapy is important and that it improves survival really started to take hold. And so we've gone back up from 55% to 75%. So don't cheat, and brachytherapy for the whole countryside. This is something more wise than I would have to say, but one of my favorites, gratitude turns what we have into enough. So along that line of from beginning to end, this package time, we've got staging and workup. We have to decide, for a time, we would decide between 3D and IMRT. Here's an interesting one. Don't tell your physicians I told on them. But who did, the 3D whole pelvis blocks? Most, I would have thought more. But the 3D pelvis, 4-field, physician draws the blocks, turn the beam on, isodose, scale it up or down, and then we're good. The first major trial out of India showed us that there was no difference in toxicity, bowel toxicity between IMRT and 3D. And if you've seen those 3D plans, they get everything. I mean, they're corner blocks on the bowel, is what we call them. But then the US, we put out the RTOG time C trial. And again, we see no difference at first. But if we waited long enough and if we did some statistical gymnastics, then we found a statistical difference. I actually do believe, anecdotally, watching my patients, having treated a lot of 3D and IMRT, I see a difference. But it was hard to quantify, I think, as part of that. And so I'm so grateful for the time C trial and that now we've got approval for the IMRT plans. But selecting an applicator, that's the next big part, right? We got our intracavitary, our interstitial hybrids, and our interstitial, and then our hybrids that have some of each. Do we do a parametrial boost, something of the past? After the brachytherapy plan, then looking at sidewalls, what does it need? This one's a little bit more art and spitball, I'll be honest. It's some pattern of how you were trained. And then how many days do we do brachytherapy sequentially after we've finished external beam? Can you interdigitate it and when? And the package time, and then nodal boost afterwards. Because brachytherapy is not going, gross disease is always going to need more than our microscopic disease, right? And so brachytherapy is our other half of treatment for these patients. We give half of it over 25 torturous days, external beam. And then we do half of it in like 5 days in brachytherapy, but that doesn't reach the pelvic lymph nodes, para-aortic lymph nodes. So that's why we, patient thinks they're done, physicists think we're done, and I say, all right, sim them again. Let's go. So letting patients know up front is really important. And then follow up. So here was one more piece by Retro Embrace. They showed that taking it from that 56 days and moving it to a 49 days of package time was the equivalent of giving the CTV, high-risk CTV, another 5 gray okay, and improved local control by another few percent. Thought that was interesting, and this was in a time of chemotherapy, whereas our other package time was pre-chemo. So workup, what am I doing? I meet a patient, physical exam, I want to know if they've got an os. That tells me, is there any tandem or that tube that goes through that we can utilize? I love a tandem when we can get one. Fornices are second. Fornices are kind of that gutter, the rim around the cervix between the vagina and the cervix. If I've got good fornices, I can get ovoids or a ring kind of flush up and against. If I don't, then that's going to change which applicator possibly, or if I need interstitial needles. Vaginal involvement, is it high or low? If it's low, we're talking interstitial. If it's high, that's probably something we can still catch with our pear-shaped distribution. Gold seed marker placement, I like to place those afterwards now. I used to place them, the tumor would have a good response, and then the gold seed would just fall out somewhere because it was in tumor, right? That was responding through external beam. Parametrial and uterosacral involvement, those affect my contouring. And so if I, on exam, detect uterosacral involvement or parametria, then I'm going to have different margins. And we'll talk a little bit more about that. Oh, let's go back. I got ambitious on my laser pointer. What was the Star Trek?
Phasers.
Yeah, the phasers. MRI, I do like vaginal gel in there because that expands the vaginal tissue, gives us more clarification of not just a bulk, but where's it attached. Dang it. I keep hitting you with my applicator size is MRI helps us there. The fundus, how far is there disease in the fundus? That changes our loading. Nodes, whether it's 4A disease, 4A is if it's contacting or invading other pelvic normal structures. The PET is a must because it tells us which nodes are going to be boosted, which are not. We'll have a case that I think is my most impressive or the most impressive I've had for a number of nodes. And then cystoscopy, proctoscopy, if we think there's invasion into those structures, labs, infertility, that one I meant to do. So first case, 38-year-old female presented with postcoital bleeding, exam, biopsy, MRI, and PET. So here, this is a profile view or a sagittal. I love that I can say that with you guys. But sacrum right down the back here. This is rectum in the back. You can see the vaginal gel. And so if we didn't have that vaginal gel, we'd have a big mass and I'd be unsure, was that going through the posterior wall? The vaginal gel kind of clears that up. We've got bladder in front, pubic symphysis. On a T2 high res, that's our gold for imaging on cervical cancer. You can see the fundus up here, pretty uninvolved, but a remarkable, tumor here. I think that we were probably somewhere around 8 centimeters. This is an axial. And so again, no posterior wall involvement, mostly anterior. This is bladder up here, tumor, the rest of the vaginal vault, and then the rectum. PET scan, a little hard to really tell, but you've got a lot of PET avid disease here. Okay, we've got a good pelvic lymph node on the right here. And then I tried to catch the multiplicity of lymph nodes going up. She has more than 25 PET avid lymph nodes, and they're going all the way up to the renal hilum. Years ago, we would have said, that's too much, cannot cure. We may not have had chemotherapy, or we didn't have IMRT to boost these nodes, so they would get 45 gray, or if someone was really gutsy, they would take it to 56 and wow, some rip-roaring toxicity. This is our second case, and we're going to do these in parallel. We're going to have an intercavitary and an interstitial as we go along. What time do I go till? We started a little late, but I don't want to.
10:30 was the scheduled time.
I will move. Interstitial. So with this patient, do we have a lot of people online? Should I use pointer or am I okay with roam?
Either one, they can see you pointing,
Okay, they can.
I think. I'm sure.
I like to point better. So cervix, this is towards the top, vagina, and then this is a massive parametrial. There was attachment to the sidewall. Over here, it was kind of attached to the ovary. This is axial again. This one, this is why sometimes I'll ask you to fuse both an axial and a sagittal of the same T2, because this is what it looks like as a sagittal reconstructed, especially after we, change our angle and we fuse it, then the imaging integrity gets kind of lost. But you can see also very large bulky tumor, bladder, rectum. This one is a coronal. And so you can see this is vagina, this is tumor starting, this is still mostly vagina. Cervical os probably started around here, and then we've got fundus. And so a very different case. This gal had pelvic pain and some bleeding. This is her PET scan, and really just drawing attention, bulky pelvic mass, but then just one larger pelvic lymph node. This, maybe we'll go through a little more quickly. This is kind of really the update and treatment slide, less relevant to physicists, but this is where we're advancing, I'd say, in most places for cancer, or immunotherapy. The interlace trial on the left, this was European and chemo prior to chemo radiation, and it's got longer follow-up. It's got good improvement in survival, but now we've got the keynote, which is immunotherapy, and that's immunotherapy given from the beginning through chemo radiation, brachytherapy, and then finishing many months of adjuvant. But you can see here on the overall survival, we've got a 12% improvement in overall survival. Overall survival is really hard to get anymore. We're winning a lot of that, but now we're having these leaps. Instead of 2 and 3% improvements of overall survival, immunotherapy is finding us again into these 10 and 12 and 15%. The chemo helped a whole lot here, and we see over here at 36 months, 82 versus 74, some criticisms that this one did have more favorable patients. They didn't include anyone with lymphadenopathy outside of the pelvis, periaortic nodes, whereas the keynote had the true advanced patients. Immunotherapy is going to work systemically, and so that's where we hope to see the most improvement. White-class words of wisdom: if you give a man a fish, you feed him for one day. If you feed him to the fish, he'll never be hungry again. So these are those 3D pelvic fields. Physician, I would draw 2 blocks. You guys would parallel oppose them. We would turn the calculation on. We'd see where it was, maybe block some hot spots. When we got, more of the field in field, sometimes, but a little less with pelvic than some of the rest. This does come from data. So how and why we contour. This is a map essentially showing where lymph nodes occur, in which patients at diagnosis is on the right, and then nodal failures. And you see that we cover those iliac nodes pretty well, but that we fail in the PA nodes. And so these boosts help a lot. For you, here's some resources. eContour is free. If you're ever wondering, is this right? Or I've got this new physician, is he right? eContour, you can put your name in there. They don't give you any spam. It's University of San Diego that started it. And they've got cases for everything. This is head and neck through cervix cancer. So great resource. IMRT margins. This is evolving. And I would say right now, in my opinion and observation, it's mostly a physician style with who is doing what. These are changed a little bit because now we do the full and empty bladder, create an ITV, and then it's a little bit more of a, what's your experience been on setup and what the PTV should be. Before ITVs were created, these were studies that showed us that on gross disease, you needed 15 millimeters. This is for cervical. This is not for nodal. Nodes are usually a little more fixed. For the boost, how did we figure, I was really afraid in 2016 of how fast could I give an SIV to these lymph nodes. Otherwise, we'd be doing eternal nodal boosts after brachytherapy. And so these papers were really key in allowing us to get to usually my pattern is 55 gray and 25 fractions to gross nodal disease. And then you can follow that up. Brachytherapy will usually contribute like 1 or 2 gray, sometimes up to 3, depending on how close, how big your implant was. And then if you do your EQD2, by then you're already up to about 60, 61 gray. And so your nodal boost after brachytherapy that you're doing sequentially, usually you only need about another 3 to 5 gray and you're at full dose for gross disease. So the other mystery for, I'd say, ages, I still even look at this a little bit when I'm treating things like prostate or other pelvic. The eternal debate, Quantec did a really great job of describing what the rectum could take and what the colon could take and what the small bowel could take. But everyone, for the longest time, it was like, but what does the duodenum, or sorry, I'm on the wrong slide. What does the sigmoid do? I'm on the duodenal slide. So we'll get to the sigmoid. But here what we see are these sloping lines statistically are 95% confidence intervals. After 60 gray, we're unsure. And so that's why you see so many of our constraints kind of reach that 60 gray and then pull back. We've got some better constraints now when we're high up in the PA nodes because we're always right next to the duodenum. NCCN, luckily, 2026, now they've put in the answers for us and collected. It used to be that you're collecting from the Embrace on this one and this American trial on another, and then everyone was making their own dose constraints. But now NCCN, and I agree with these are all up to date. This is our patient with the intracavitary. You can now appreciate her gross nodal disease on this image. This was one of the trickiest hotspots with bowel, and should we consider the hotspot that's inferior to be, to add up with the CCs of the hotspots that are way up by the kidneys? My answer is no. Those are not relevant to each other. As far as late tissue grade 3 complications like ulceration, right? Dose down at the bottom of the pelvis doesn't add to the up near the kidneys, but for overall bowel function, it does, because as you increase these SIV boosts, well, integral dose goes up and our mid dose goes way up for all the bowel. This is our interstitial contouring. And now we're going to go to cervical brachytherapy. Wrong cervix. Wrong cervical area. I don't know how we got red lines. Thank you, Mr. Bohorquez. Well, we've underlined reach 25 to 35. So let's spend some time there. Is there any way that we can get rid of that? Brachytherapy, choosing the brachytherapy applicator. We start with our intracavitary. Intracavitary, in my mind, if the disease is symmetrical, then I'm thinking 2 centimeters to each laterality. If it's beyond that, then I'm either going to be really heating up my tandem and ovoid plan, or I'm going to be short on dose. And so at that point, we've got interstitial brachytherapy, SIADs, and that's going to reach pelvic sidewalls, lower vaginal involvement. But I was so grateful when they started to create the hybrids. Hybrids get us to reach about 3.5 centimeters to each side. If you have, so the Venezia, I shouldn't say that because we have a variant rep. I love the Venezia applicator. I've never had one in my clinic, but been able to use it and see other people's. But there are applicators that are interstitial hybrids where it's only hybrid above the cervix. Okay, so that's where it gets tricky. Because like one that we have, Varian does have a good here's your plug variant. It does have a good interstitial cylinder, but it's a cylinder and then it fans out. And so in that fan, if you have disease immediately lateral to the cervix, you can't get it. And so there are other applicators that they do have, but finding these interstitial applicators really took a big chunk of these patients that were having intracavitary and having underdose or too many side effects, because that inverse square law, if you get the tumor, you get everything else, right? And so it eliminated those, and it took a lot of people out of that interstitial brachytherapy that it was like, oh, shoot, they're just a little far. I need to do a SIAD. And then they're admitted and on their back for 3 days. Thanks so much, Olivia. Okay, that's it. So applicators, we talked about 2 centimeter pair dose, largest ring. You want to put the largest ring that you can accommodate. Again, inverse square law tactics. Our interstitials, you can get up to 3.5 centimeters. In the papers, there's only load the interstitial needles up to 10 to 20% of your total load or dwell time. I did ask Carrie Tandrup and Mr. Peters, both Vienna and Holland, and they said, we made that up. Serious. It was at Astro, because I was just like, look, I'm having a hard time. I'm using these because I want to get it there. I want to get the dose there. I'm having a hard time. And they said, we just, on first push, when we sent this out, we wanted people to be safe. And so we thought that was a reasonable thing. And I said, do you follow it? And they said, no. Is this recorded? The thing that we're concerned about is ureteral stenosis. And we've got now this trial that shows us on retro embrace 2.5% at 5 years when using these interstitials, the hybrids. So this is the Muppet applicator. I think the name is great. Jim Henson would be proud. Anything not reached by intracavitary or the hybrid, T4 disease, parametrial, mid-lower involvement. So placement, you guys know, I'm going to keep moving to some more interesting things. Intracavitary. So this is the response. Again, she had immunoradiotherapy. And so this is her axial, almost no disease. This is the disease here. This was her previous axial. Okay, so that's the amazing response some people have. When your physician comes to you and says, we've got a possible SIAD, this is why I want you to have some grace and some mercy, because it may respond like this. And she turned into an intracavitary, though we had done all the pre-work for a SIAD interstitial implant and talked with the OR and all the scheduling. And my nurses probably get the real brunt of the scheduling of let's schedule both. And then we get the MRI and poof, one of those just disappears out of thin air from options. You can see, again, tumor here underneath the cervix. This is the comparable sagittal. There's no tumor down there. Her Oz became visible. We were able to put seed marker in there, implant. Here is our implant. We won't spend a lot more time. So sim and contours, I still put the ICRU points in. That is not, I'd say, as required, except for the rectal vaginal point. That one is a decision maker still. We'll talk a little bit more about that. But you've got your GTV. I would say by practice, HRCTV in the US. Some clinics do the IRCTV more religiously and use it as a decision point. The important thing here is with brachytherapy, we're no longer moving to image-guided brachytherapy. As we move to image-guided brachytherapy, and we're no longer prescribing to point A for everybody, we see what the response is, we treat, but what we don't know is this. If I have a complete response or a near complete response in the cervix, and so now I've made a really conformal and tight brachytherapy plan, Same question with any image-guided adaptive radiation is what about the subclinical disease we have just made from gross disease now into subclinical? What dose does it need? We don't know. What coverage does it need? We don't know. And so instead of making the mistake of, oh, it's smaller, let's treat a smaller volume, it's let's treat a smaller volume, but then the IRCTV and point A for me still requires a certain dose. 65 gray at point A is something you want to watch. So that then it's not we totally cured the center, but as things adapted in our treatment, we allowed for subclinical disease to live. And then they have this bilateral parametrial disease recurrence. Not something that I've ever seen, but I don't ever want to see it. But at least that's why we're still careful. We still look at point A. And if you don't, the IRCTV is especially important. So Simon contours, Jack Estro, I would say if you take anything from brachytherapy talk today, it's that you need to know the NCCN guidelines, which is the conglomerate of Embrace 2. Okay, print off the Embrace 2 protocol is everything. If you print that off, it's 121 pages, something like that. But it's really easy. It's like Europeans have this way of giving us the information we need and nothing more. I don't know if it's just because we need more verbiage to get our grants here in the US. But they put it in there and it's like picture, evidence. This is what we recommend. Picture, evidence. This is what we recommend. So Embrace 2, the NCCN guidelines, are, if you were to take anything home, you would do well there. So brachytherapy, we're looking at coverage, of course, constraints, loading, hotspots. DHI is different. It's our dose homogeneity index. In breast, in prostate, we want these, more homogeneous. But in cervical brachytherapy, we are looking for hotspots. And so throughout the window, if you've done a lot of savvy balloons or prostate brachy, that DHI almost, because it's just not as relevant. Dose planning, Kevin Albuquerque, physician, put together a wonderful paper years ago of the brachytherapy dose compendium. If you just looked up dose compendium, it's going to give you all of the most accepted brachytherapy, not just for cervix, but endometrial, vaginal, and then after external beam, treatment alone. So that's another place to look. So a little time here. I like looking at dose constraints over time. Here's where it's helpful. If I have a patient who's got a really bad tumor and their bladder's really hot, and I've only written down in our agreed upon local physicians dose constraints in ClearCheck that 75 gray is my target, then the next physicians that come in are also going to shoot for 75 gray. And if every physician only goes for our ideal, then they're missing it. Because if you get a tumor where you need or you could get excellent coverage and you could be at 80 gray, or if you have to be on a fraction or so at 90 gray, you can know by knowing your constraints over time where you can start to fall back to and say, well, you know what? I know that historically, instead of having our risk be below 5%, I'm going to accept in this case 7%. Well, that's totally reasonable. I don't really know what the difference is here, but it's going to be a handful of percentage points in toxicity. And certainly the first failure that you get, I'll never forget in Omaha, a gal from South Dakota comes down for brachytherapy, 10 centimeter vaginal tumor. We implant it with needles. And I just have this like gut feeling of this is not the usual. This did not respond well to external beam. It was sent to me from outside after external beam. We did the implant. I made a perfect plan. It's just a circular tumor, almost like a pipe. And so it just was made. We got the implants in exactly how I wanted geometry wise. And then I planned and I met every constraint. And I will forever regret meeting every constraint on that one patient. There are some times where you look at one of my mentors, Chuck Inc., he would say, don't kill your patients with kindness. And what he meant was, if you always meet every constraint, you may be cold or you may not get your local control. And the worst side effect could be a recurrence, which is not curable. So dose constraints, to me, I love to see some fluidity. And where do these come from? Most of these have a really specific study where we're able to kind of find that therapeutic window and say, this is a reasonable dose that we can get reasonable outcomes with. Looking at hundreds of brachytherapy cases, what were the average doses? But in the end, this is where we get. Embrace is the most aggressive, aim of 90 to 95. NCCN new is still 80 to 85. I do still shoot for that 90. But if I've got a big sciatic, then I know that I'm not shooting for 95. Again, a reason to know many constraints over time, because it's not reasonable to try to make everybody into one. We've got the bladder study here. We'll move a little bit. If you find a toilet in your dream, don't use it. The sigmoid. So sigmoid and small bowel, when you're external beam planning, we are so careful, and it's like on a prostate, we just won't let the bowel hit 60 gray, but we do need to remember that bowel is moving. And in brachytherapy, we see 65 on the duodenum or on the small bowel all the time. Knowing, again, dose constraints from other sites of disease, right? If we treated everything per lymphoma, which we're getting 20 gray at a time, we would have unreasonable dose constraints for the lung and the heart. But if you know, and so I've got a chart in the table where it's heart constraints, and this is for lung, lymphoma, anything that would be in the chest. And so I know, okay, these are within reason. Sigmoid, of course, if you give too much radiation, the uncomfortable side effect, diarrhea, I would say 30% of my patients I'm treating for cervical cancer complain of diarrhea. I'm not sure if that means that the other 70% enjoy it. The rectovaginal point. So old, point dose from way back when. We still use it because this is actually a study showing that our vaginal stenosis, one of our biggest predictors, and I would say biggest predictors in that it is the most statistically significant, the most reproducible. There are other, the PIBS line and how much is your 150 or 120 line contacting, which is hard to quantify. But that's for the vaginal stenosis. And so I still keep that one as a treatment plan quality metric. So this is our interstitial. And you see, she didn't have as large of a tumor, but she also didn't have as much of a response. So this was our patient that had external beam immunotherapy and then did not have as good of a response. So she's going to brachytherapy. I want to spend a little bit of time here. Kemp Physics does an awesome job of a pre-plan. Not everybody does this, but this is my decoder ring. Okay, I have, they will print this up and I tape it in the OR. And so I've got my decoder ring that doesn't tell you to drink your Ovaltine, but where to put needles instead. And so we've got both afterloader numbers and what number needle it is on the template. And then what we do is a pre-plan. We take that MRI. I do put the applicator in. We do a CT sim, and they're able to kind of construct a fictitious plan and know which needles will be used, which are important, which are reaching hard to reach areas, what won't be reached or what's not expected to be reached on the brachytherapy plan. What's next to the bladder or will go through the bladder? What will go through the rectum? What is close to bowel? And what's close to the internal iliac arteries? The iliac arteries, I will plan them about 1 centimeter or 2 short. And then when we do the CT sim, I just know those are 2 that I'm going to push a little bit more at the time of CT sim, knowing that I'm not going to puncture that internal iliac. You puncture one of those and there's probably not a surgeon that can save them fast enough. Though I've never heard of it happening. That it scares me to death, but I've never heard of a patient getting it. I would think it would be published. But you can see the pre-plan. And then I've got the sheet. This is not the same patient, so the needle lengths don't apply. But I tried to get it so that we've only got about 3 levels of depth. So it's not every needle is a different depth. That would be your nightmare every time that we're measuring after we bring the patient down for another fraction. So I try to have about 3 depths, but then we'll also label them and we'll even do like triangles around the number if it's close to the rectum, a circle around it if it's close to the bladder, and then a square around it if it's close to the internal iliacs. Then when I'm placing needles, it really is like Battleship. I'm like, oh, 1 goes to this part of the template. I'm going this deep and I'm being careful of the bladder. So on imaging, it's just a really good systematic process. Here is the actual implant. Went remarkably close on this one to the pre-plan. That's not always the case. Sometimes I'll put the applicator in while they're awake and they're a little more tense, and the applicator, goes right flush against the tumor because they're holding. And then when they're asleep, and their legs are up and they're under anesthesia, everything's relaxed. I place the applicator in and it slides to the posterior fornix and the tumor shifts anteriorly, and then all my needles are off. So in your pre-plan, if you do that, know that there's going to be variation and go for needles outside of what you need. Place needles a little further than you need. That should be a part of the pre-plan. So then we've got QA, delivery, removal, revise the plan for the next fraction if it's multiple insertions. And this is our intracavitary patient. This was our boost now. We're able to meet most constraints. This was her post-treatment PET. So you see no avidity in the PA nodes. Complete response in the pelvic and PA nodes. Can anyone pick out what's wrong with this picture? The radiologist didn't either. But there's one cervical node. Not cervical node. But oddly enough, Virchow's node, there is well documented that the lymphatic drainage can go from pelvic structures to the left supraclavicular region directly. So not need to travel through the mediastinum. This, of course, received the chemotherapy, which is more low dose when we're doing it with brachytherapy, but it was essentially untreated. And so everything that we treated, complete response. Now we've got a 37-year-old gal with a supraclav node. Korea and then a few other US institutions have discovered that if we treat those aggressively, we can have up to 40% of these patients have long-term control, I'll call it, but we're talking 5 years, no disease. In the cervical cancer world, that's pretty much, I would count that as road to cure. And so for her, she ended up getting an external beam boost. Those studies use conventional fractionation. Something that I like to do is SBRT, 40 gray to that node. This one 40 gray because it's right next to the brachial plexus. I'd give it 50 if it was in a safer spot. But then 25 gray SIB to the regional nodes, because what we find is the studies where they just did SBRT to just the node, we had a near field or a field edge recurrence. And so we did, and I get to tell her next week that she's right now disease-free and that we'll follow her. If you surf with a friend, your chances of getting eaten by a shark drop by 50%. That's perfect timing. Something bigger, we started with, no success in our careers makes up for not seeing people one by one. Whatever it is for you, there is something bigger. And so if it's lofty ideals, if it's principles that you live by, that someone you love taught you, if it's your mentors, if it's love, if it's a higher power, or if you name it, in any case, if you have something greater, then I'd say to see these patients and the people you work with, see them the way your something greater sees them. What is that to you? And then once you've seen them the way your something greater has seen them, you want for them what your something greater wants for them, those principles, those ideals. And then after you have wanted, then we can do for them what our something greater would do for them. So long, and thanks for all the fish.
Any questions?
So it looked like you had regional lymph nodes for the vaginal cancers, 71% as being, you had a big circle of 71% on the right, but then you said that the cervical lymph node, it goes there, so it crisscrosses the
Yes, so that previous of what's the incidence of pelvic lymph nodes did not, that was pre-understanding of can we treat these as regional disease if it's in a superclad. Was that your question?
Yeah, so because it crisscrossed the body, so it was right side, and then now it's on the left side.
So we would believe, so the question is, does it cross from right to the left? Virchow's node is traditionally, and unless you're an anatomic variant, it's from cervix or pelvic structure directly to left. I haven't seen any on the right.
Any other questions? One in the back?
So where I trained, which was not that long ago, there was a philosophy of the physicians that I worked with when doing cervical brachytherapy with like tandem and ovoid interstitial mix to like, you start with your pear shape and then you add your interstitial point. But there was a very strong philosophy to like maintain that pear shape as much as possible. Like don't load your posterior or anterior points in your ring. Don't like overextend your points in your needles. Versus philosophies that I've encountered after that where, you can load all of your points and just pull your isodose lines until you cover your tumor. Is there like do you think that like the philosophy I trained with was more based on that, like maintaining the 10 to 20% sort of rule, or is there a like physical reason why you might not want to use all of your loaded points and kind of try to be thoughtful about what you're actually loading?
I think so. What you're asking is two ways to get to an end, and which is better. And
Yeah, kind of. Is there a fundamental reason why like you would want to because
start with
doing it the
shape.
former way is a little hard to get your coverage. Like sometimes you accept lower coverage because like you're not loading those additional points. But
So
is there a reason really to not load those points?
To me, to start with the pear shape makes the most sense for me. So I'm biased because that's my experience and it's gone well. Here's what I think is starting with that pear shape, and even with an interstitial, if you've got a tandem, use your tandem first and maximize that tandem because we know what that does. We know that's with, we know what the dose distribution is going to be. It's most reliable for reproducibility, and then adding needles afterwards. But the tricky part, I imagine, is that most software now, it's much easier to inverse plan brachytherapy. And so I think that that's where people are getting more comfortable. But what could happen is if you're not paying attention to all the details, you could have ridiculous hotspots that are not in places we used to have them. Having the 200% line run the tandem, no big deal, right? 150% line to kind of pooch out. I don't want the 200% line to connect from ovoids to tandem. But if you start to just pull on isodose lines, it changes so many things that I'm not accounting for. And each time I pull, like, we do turn it to local from global, grab the isodose line and drag it. It does so many things I didn't account for. And it would, if I was to do it in a really good way, it would require me to do an absolute complete recheck of the plan. And so that is a little more anxiety producing to me. And so to start with a traditional plan and then add to it, I think makes a lot of sense, though it probably caused my physicists more work if we did it that way. Good question.
All right, thank you. Appreciate it.